Thank you, Mr. Chairman. And I would say to the ranking member, I am very pleased to hear that the pastor, it is rare for him to be in a bar late in the evening, so much so that American Express calls him and says it's a rare event. So glad to be able to hear that. Let me bounce a couple of questions off of you as well, and I have some real concerns on the RAC audit process. If there's any one thing that I hear from hospitals, providers, and folks the most, it is the full-body cavity search that has become the RAC audit process. I have several concerns. One begins just with the process of it. As a Federal Government, we are designed to serve the people rather than them serve us. And the RAC audit process seems to put the whole process on its head, that they exist there to serve us and we're going to stay long enough until we find some fraud. The contingency fee process part of it, my fear is turning this into a bounty hunter process, that we have outside contractors that are coming in and they're going to stay until they get paid, until they find something there. That moves the system significantly towards we're going to find more fraud, but it also moves the system significantly towards a hostile, not helpful environment in that. Saying all that, that's where we are, I feel. I don't know if anyone disagrees with me on that. I've yet to find anyone that disagrees with that, and I've had multiple conversations with that sense. If you've got a disagreement, I'd like to hear it, but I'd also like to hear how are we preparing people for these RAC audits and what process is occurring currently, so when people arrive, it is an environment where we evaluate, as we should. We should hold people to account, but this should not be a hostile event.
Representative Lankford,
Yes, ma'am.
As you may know, the RAC program started with a demonstration,
right,
and we evaluated that demonstration, and we did find a number of areas for concern. And there were some missteps on the part of CMS in terms of the issues that were explored there and, perhaps over-aggressiveness. And I think that CMS, in implementing the national program, took a lot of those concerns into account, and they devised a system at CMS where all of the central players in the operation would get together and agree on what kinds of situations the RACs could look into, rather than having them just go out on their own. So in the national program, I think that part has been smoother.
Still paying people a contingency based on what they find.
That's the way the program was set up.
That's the way it's set up.
To pay on contingency. But one other thing I might add about that is the RAC program is designed to identify overpayments and underpayments, and it's not specifically designed to look for fraud. Right. It's really looking at cases in which the agency has paid too much or too little.
Right, but a lot of the underpayment, what do we have, a 4% national rate for underpayment?
The vast majority are overpayments.
Yeah, they're really going and looking for overpayments, obviously, on that. And that it becomes an issue of what is an overpayment and how complex this is. My assumption is it's typically we overpaid you because we shouldn't have paid you at all for this, because we disagree you shouldn't have had them in the hospital 2 nights, or we disagree this shouldn't have been an overnight stay at all, or this procedure or this coding. So agree or disagree on that?
I agree, but they are following Medicare policy when they're doing the audits.
When the hospital responds back to it, when there's been a denial, my understanding is there's about a 75% rate of turning that over. Am I correct or incorrect on that?
When we did our work, we didn't have the information about what the overturn rate is.
Well, the appeal rate seems to be extremely high. When we're looking for fraud and we're fighting back and forth on whether this should have been through the process or not, whether it should have been a 1-night or 2-night or overnight at all or whatever it may be, and then they appeal it and have a 75% appeal success rate, that tells me there's still an issue. There's still a problem hovering out there somewhere that we've got to be able to resolve, because we are creating a hostile environment with providers. This is someone we should be serving. We should hold people to account, but we should also be serving them rather than creating an environment where they're spending tens of thousands to hundreds of thousands of dollars defending something that was valid.
We haven't looked at the implementation of the national program, so I really don't know there whether the appeal rate has gone down, and we did not have access to the appeal data during the course of our work. So you're raising valid concerns, but I don't know the answer.
Okay, Mr. Bedell, you look like you were going to say something.
Yeah, if I would just add a couple of things to that. One, I would echo what Ms. King said, but I would also add that CMS is listening to those kinds of concerns that you've identified. We've certainly heard them as well. We have put into place a demonstration project in order to work with hospitals when there's a question as to whether or not the patient should have been an inpatient or an outpatient, and set up a demonstration where hospitals can rebill if that's the determination, so that they don't lose the entire payment as they have under standard operating procedures that have been in place. We're also very much looking at all of those concerns, and they're the matter of a great deal of internal discussion in the agency at this time.
Well, I would encourage you to keep it as a matter of a great deal of internal discussion so we can try to evaluate it, because this obviously is an issue. I know this is a project you're trying to launch on it, but we've got to be able to resolve this. With that, I yield back. Thank you.
From Oklahoma.
Thank you. Let me do a quick follow-up statement. Finish out talking about the RAC audits. I do have a statement from the AMA about the RAC audits. I'd like to be added into the record.
Without objection, so
questions and issues that they had as well. Is there a system in place? When you're still with coding and billing, some of those things are automated. Obviously, when they go through an audit, they can get a chance to look at those, and those will bounce up. When I do my taxes, go through a program, at the end of it, it comes back and does a red flag for me on everything to say, okay, double check and make sure this is correct. For providers, do they have any system like that so that before someone comes in and does a RAC audit, someone is checked and rechecked locally? This might come up as a question. This is not consistent with typical billing. Is there anything like that that's in place for the providers?
I do know that there are a number of reasons why claims are not accepted the first time around, and providers get information back on the claims. But I really can't speak to that in exactly that point in detail. I don't know if
this is submitted online and submitted through a program, right?
Most bills are now. Yes.
Right. That's what I assume. So what I'm asking, is there a way to be able to set that up so it's built so it checks it locally before they ever submit it, that there's a quick verification of that to say, double check, this line was left out, this code seems to be inconsistent with this one?
That's not something that we have ever looked at, but my understanding is that the providers do use software billing programs that would enable them to check for those kinds of things.
But you're saying that's not something
that we have looked
provide.
At.
They purchase a separate one that actually attaches to that, a third-party software somewhere that does that.
Yes, sir.
Because obviously the goal of this is to right the first time, not that we're paying chasing, and not that we're trying to do a RAC audit to be able to come down on someone on that.
Right. Our statement does talk about CMS's efforts on the Medicaid side in this area, looking for prepayment edits. CMS has to date looked primarily just at the process for doing this, not necessarily at the content of the individual edits.
Right.
They have identified some notable practices, some of which sort of stop the claim and identify what information is necessary.
And on the Medicare side, we are doing a significant amount of work on Medicare prepayment edits so that Medicare would not pay claims that are not in conformance with its policies or providers who are not eligible. But that's, I think that you were asking a question that, on the provider side, what do they do so that by the time they submit a claim, it's clean?
That's correct. Yeah, the goal is that when it's submitted, it's clean, it's been checked and rechecked, and then they have some confidence that this is going through on it. Mr. Maxwell, I'm very concerned on the data matching, the Medi program, and your testimony that in previous years we spent $60 million on a program that recouped $57.8 million. That doesn't seem like a real great investment in the process. The question is this a program that can be improved? Is this a program that needs to be terminated? Are there ideas that have been submitted to what to do with it at this point?
The core issue that I bring up in the testimony today is the fact that the program is supposed to be matching Medicare and Medicaid data, and yet it doesn't have the Medicaid data to match. So it's perhaps not surprising that they're not finding as much as they would expect, and certainly they're finding very, very little on the Medicaid side for that reason as well. So to improve that program, and as well as the MIC program that we talk about, really it goes back to the Medicaid data. We absolutely need national standardized Medicaid data to make these programs worthwhile.
Is there a reason that the Medicaid data can't be standardized to the Medicare data as far as how it's drawn in from a provider. Obviously, most providers do both anyway, but those systems can't be consistent.
Just to engage this a little bit, Mr. Lankford, the Medi program operates on a state-by-state basis, so that the contractors who are actually the Medicare investigative contractors work with the state. And as I said before, when I was talking about expanding our collaborative audits, we believe that this is a framework that we can use for enhancing our ability to work with the individual states. We have some 15 states now representing well over half of all Medicaid expenditures that are in the Medi program. A couple of those states have recently, one in particular, we believe has recently shown that with appropriate use of the Medi approach, it can have very substantial returns. And so we believe that this is a way for us to build out part of our collaborative approach with the states, because being on-site with the states, working directly with them, and engaging them with both the Medicare and Medicaid data.
So what is an appropriate return? Obviously, spending as much as you get back in is not an appropriate return.
No, the return that we're seeing in more recent times is much higher than that. I don't have the numbers in front of me, but I'd be delighted to share them with the committee, because we believe they're very positive. But we think there's more to do. There's definitely still more to do.
Okay. Thank you for that. I yield back.